So we would like to have the third speaker, Dr. Hitoshi Matsuda, the Director of the Vascular Surgery in National Cerebral and Cardiovascular Center, Shita, Japan. He will present the topic about the persistent type 2 endoleak after EVAR and preventing measurement.
This is my first visit to Thailand, Phuket 10 years ago for Philips meeting, Shirat Hospital 4 years ago to observe art by Dr. Kami, and Chiang Mai in 2020 to attend Asian Society of Cardiovascular and Thoracic Surgery meeting. Left row is in Singapore with Dr. Boon Prasit 10 years ago. This is my hospital, National Cerebral and Cardiovascular Center, Osaka, Japan. I am working with 2 senior, 3 young faculty surgeons for about 400 aortic surgeries per year, including both open and endo, and 250 thoracic and 150 abdominal. About endoleak after EVAR, additional treatment will be considered for malignant type 1 and type 3, and follow-up is common for benign type 4 endoleaks. However, type 2 endoleak still remains to be controversial for its nature. I would like to go back to the prevalence of type 2 endoleak. In this meta-analysis of 45 papers and 36,000 patients, type 2 endoleak was found in 22% patients. In EVAR trial, sample size was not large, but delayed type 2 endoleak were associated with late aneurysm enlargement. This is Japanese registry data of 38,000 patients. Again, type 2 endoleak at discharge resulted sac dilatation in 5 years. In this registry, ENGAGE for Medtronic endulant showed type 2 endoleak in 20% patients, and a small group of patients with type 2 will present with a type 1, resulting in a high secondary intervention rate and significant risk of aneurysm-related complications. We started EVAR program in 2007 and focused on type 2 endoleak 2009, after 2 years after starting program. In the beginning stage, IMA embolization was indicated after sac enlargement was confirmed. However, secondary IMA embolization utilizing triaxial microcatheter technique via SMA needed 3 hours to complete. Our initial data about IMA embolization simultaneous with EVAR just needed 30 minutes. This paper is published 2014 from our department, but reported our initial indication of IMA coil embolization. In patients with persistent type 2 endoleak, IMA diameter was 2.5 millimeter or more, and no stenosis due to calcification or mural thrombus in IMA orifice was observed. About other source of type 2 endoleak, a number of patent lumbar arteries were found to be significant. 4 or more patent lumbar arteries revealed degrees of freedom from sac enlargement. To conclude the clinical significance of type 2 endoleak, we conducted a nationwide survey in 17,000 patients from registry of Japanese Committee for Stent Graft Management. This committee, JAC-SM, is made of 10 Japanese medical associations relating EVAR. Risk factors of aneurysm sac enlargement after EVAR were investigated by this study. From 21,000 patients who underwent EVAR between 2006 and 2015, younger than 75 years old at the time of EVAR with no type 1 nor 3 endoleak, after 4 steps of exclusion criteria, 17,000 were enrolled and divided into two groups, with persistent type 2 and no-endoleak. In overall comparison, almost no difference was found except for gender, etiology, neck thrombosis, and neck angles. Even in no persistent endoleak group, type 2 endoleak was found in 10% patients intraoperatively, but in persistent type 2 endoleak group, more than 30%. Cumulative incidence curves of persistent type 2 endoleak group revealed worse aneurysm-related mortality, rupture, sac enlargement, and re-intervention. To remove the difference in patients' background, about 5,000 patients were matched using propensity scores. Again, cumulative incidence curves of persistent type 2 endoleak group revealed worse aneurysm-related mortality, rupture, sac enlargement, and re-intervention. Predictors of sac enlargement other than persistent type 2 endoleaks were older age, female gender, proximal neck diameter, and chronic kidney disease. About the source of type 2 endoleak, hazard ratio of IMA alone was set at 1 and compared with other sources. The combination of IMA and lumbar arteries as a source of type 2 endoleak and/or middle sacral artery were significantly worse. This might suggest reduction of source of endoleaks with preemptive embolization may prevent sac enlargement. This was coincident with paper published in 2015, which reported complex IMA and lumbar type 2 endoleak was the strongest indicator for sac enlargement, as well as the diameter of feeding or draining artery. Preemptive IMA embolization was confirmed to be effective by a randomized controlled trial by Dr. Morikage in Yamaguchi, Japan, my friend. They defined risks for type 2 endoleak as patent IMA more than 3 mm and lumbar artery more than 2 mm and aorto-iliac configuration of aneurysm. In high-risk patients, IMA embolization could prevent sac enlargement. They are now trying to confirm the effectiveness of lumbar embolization preemptively as well. This is our recent preemptive embolization procedure for IMA and lumbar arteries. Right upper time is a time of procedure. Our radiologists are doing good job, but still needs 45 minutes to embolize 3 vessels, IMA, and 2 lumbar arteries. We are now changing to perform embolization few weeks before EVAR, 2-stage strategy. This paper reported as a preventive measure for type 2 endoleak. They applied strict control of blood pressure for 2 days after EVAR and revealed lower incidence of type 2 endoleak and facilitation of sac shrinkage. About open conversion for sac enlargement due to type 2 endoleak, we have done only the ligation of patent lumbar arteries. However, in this 77-year-old female patient who underwent EVAR 2015 and 2018, type 2 endoleak was obvious, so she underwent embolization of lumbar arteries, but still fine networks was residual, and she was referred to us 4 years after EVAR. When we districtly open the aneurysm, behind white old thrombus, districtly remove the white thrombus right now. Oozing type endoleak from aneurysmal wall was found. No definite lumbar artery was found. So we decided to reject aneurysm sac completely and replaced the stent graft with new graft. Stent graft portion inside both landing zones were left, and the new graft was sutured with both aortic wall and stent graft together. After this patient, our primary procedure of surgical conversion for type 2 endoleak is a limited graft replacement. To avoid adhesive condition at landing zone, we partially remove stent graft inside. This is a paper about the result of type 2 endoleak treatment. Initial procedure for type 2 endoleak were lumbar embolization in 64%, IMA embolization in 20%, transcaval and translumbar sac embolization in 60%. And about 60% required further procedure for persistent aneurysm sac expansion after the intervention for type 2 endoleak. Freedom from repeated intervention at 1 year and 3 years was 57% and 36%. And freedom from open treatment at 1 year and 3 years was 93 and 82%. So, ladies and gentlemen, my conclusion today is risk factors for sac enlargement after EVAR, including persistent type 2 endoleak, has been revealed. Preemptive embolization might be effective to prevent sac enlargement, but still to be investigated. Open surgery with promising long-term results should be considered as an alternative choice for treatment. Koppen Club.
So thank you very much, Dr. Hitoshi Matsuda, for very impressed data about the risk factors and also the strategy for that. And I hope that Dr. Bambus is asking about the preventive is already answered by this lecture.
That's very nice data that you presented here with the Japanese Society, huge data about the type 2 endoleak. But that's a bit, I'm not sure it's conflicting with the data out from Europe or somewhere that there are, I'm sure that you may hear somebody say that type 2 endoleak is not that bad. It won't rupture that much. So don't do too much. You heard about that, right?
Yeah.
So what do you think about that idea? Let's say that I'm saying that type 2 endoleak is not that much. What will you tell me? Or what should I do to change my practice?
That is a great point. I'm chairing similar aortic master meeting in Japan for 5 years with Professor Shimizu, Keio University. And maybe the second meeting, we invited Hans Beerhagen from Rotterdam. And he says, no treatment for type 2 endoleak. And there was a huge discussion about that issue. And all Japanese doctors are envy of Dr. Hans Beerhagen. But my data presented today is too huge. So still, only that 3 to 5% patients died after type 2 endoleak residual. So your point is very good enough. If we do all patients complete embolization of lumbar arteries, the cost is too much. So now I'm changing my strategy. If type 2 endoleak is very persistent and resistant to the embolization after EVAR, we open the surgery. We convert it to open surgeries. Not so many cases. I have many cases, but not so many cases in all patients after EVAR.
What if the preemptive embolization that you suggested that IMA bigger than 3, lumbar 2 or more, bigger than 2 millimeters or more, you suggest to embolize? Let's say that if we want to do the preemptive embolization, should we do it every branch that is bigger than 2 for the lumbar, or just a pair?
Yeah, we are not sure about that. Because we walked same road we have walked same road with the previous presentation. We tried to do IMA embolization only, tried to do embolization after EVAR, sac shrinkage was not so much, and sac embolization does not have continuous long effect, only 2 years or 3 years. So we are now trying to test or examine the effect of complete embolization of lumbar arteries. But what is a complete embolization? There should be 3 pairs lumbar arteries at least, IMA and medial sacral artery. But it is very difficult to embolize all of them. We can embolize only the lumbar arteries, which is visible in the preoperative CT only. But after, other non-embolized lumbar arteries becomes the source of the type 2 endoleak. So it is a very difficult issue, I think, still.
Yeah, so Dr. Matsuda, you mentioned about the persistent endoleak type 2, right? So how long you follow up the patient to decide to confirm that it is a persistent?
Lifelong. Lifelong. Until his death.
Okay.
Yeah, we follow up the patient every 1 year until his death. So we can find everything.
Yeah. And one more thing in your presentation is very interesting. You mentioned about the hypertension management after the procedure. So can you explain a little bit more about that?
That's not our study, but first author is my resident 5 years ago. And he presented this data at SBS meeting this year and got first prize in poster session. And 2 days after EVAR, inserting arterial monitoring and controls the blood pressure, maybe less than 120 or 100 millimeter Hg for 2 days. That resulted in a very nice result about type 2 endoleak.
Because we have some bad experience from the EVAR. For the EVAR, if you keep the blood pressure is too low, then you can increase the chance of the ischemic, the spine ischemic. So how about in this situation when you try to keep the BP is low after the EVAR? How about the spine ischemia?
I don't think so. Yeah, they reported no spinal ischemia in this report.
Thank you very much for the very beautiful case, that especially that open case that you open and you cannot see the endoleaks, because during our follow-ups we sometimes get the patient like this on the CT have some branching around the sacs and expanding sac, but we cannot find the feeders or any side branch, the pattern. Also sometimes that underwent many embolization sessions already. And our radiologists, they said it might be vasculums of the aorta itself. And also, may I ask you about because some patients have some inflammation of the sacs, also some low-grade infections that can cause a sac expansion without actually in patent endoleaks or side branch, something like that. So how you can determine that situation? And also another question, what about your threshold of embolization before you convert to open surgery?
Okay. It depends on the surgeon who follows the patient. Sometimes small heart surgeon subject the patient to the re-intervention, only 5 millimeter expansion, but other big heart surgeon, 10 millimeter or 15 millimeter. It also depends on the patient risk for open surgery. And when I found type 4 endoleak, which that means the source of the endoleak is unknown, but sac expansion is obvious. We think about the type 2 endoleak and the type 3B endoleak. And if the type 2 endoleak is not obvious, we first do a delining of the stent graft inside the first stent graft. Because we have some type 3B endoleaks after open conversion, and it means nothing. Just doing relining is perfect. But after during the long follow-up, we found aneurysm wall was very fragile because there is no endoleak. The aortic wall was maybe ischemic change, very fragile become, and oozing type I presented maybe very significant. And also removing the stent graft completely, the anastomotic portion is very fragile. And I feel it's very dangerous. And so I left the landing zone stent graft inside and suture all together with a new open graft.
Just subsequent questions. And do you have the data of the pathologic report of that aneurysm wall that you resect?
It's just a ischemic change, they say. But other in other university hospital, they do they are now trying to do a more detailed examination about that issue, but they have not yet published about that.
Yeah. So thank you very much, Dr. Hitoshi Matsuda.